Hello, everyone, here in person and on Zoom. Welcome to our Department of Medicine Grand Rounds today. I'm Hannah, one of the inpatient chiefs at the University of Washington, and I'm pleased to introduce our speaker today. For those of you on Zoom, please leave comments or questions in the chat, and we'll address them at the end. Dr. Ellen Schur received her MD from Stanford Medical School in 1999 and completed a residency in internal medicine at the University of Washington. She subsequently received a master's degree in epidemiology from the University of Washington School of Public Health and Community Medicine. She currently holds the position of professor in the Department of Medicine and serves as director of the University of Washington Nutrition Obesity Research Center. After 13 years as a primary care physician at Harborview Medical Center, her clinical practice now focuses on obesity medicine at the UW Medicine Center for Weight Loss and Metabolic Surgery. As a physician scientist, Dr. Schur performs interdisciplinary research on eating behavior, obesity, and cardiometabolic disease risk in humans. Her research has elucidated genetic, physiologic, and neurologic factors that drive food consumption. She regularly gives invited lectures and presentations nationally and has published in such venues as the Journal of Clinical Investigation, American Journal of Clinical Nutrition, Obesity, Diabetes Care, and the Journal of Endocrinology and Metabolism. Dr. Schur has served as principal investigator of research awards from the National Institutes of Health and American Diabetes Association, among others. Current research uses functional and structural MRI techniques to investigate brain regulation of appetite, as well as the regulation of hypothalamic inflammation or gliosis to obesity and type 2 diabetes pathogenesis and treatment. Please give a warm welcome to Dr. Ellen Schur.
Thank you all, and thank you to those online for your attention and for joining us today. I'm very excited to be here and to talk about this topic, which is near and dear to my heart, the new era of obesity care. We're going to be going all the way from neurobiology to GLP-1 therapies today. So I want to start back in 2024, which I think was a year in which something remarkable happened. The FDA approved the very first treatment that was proven to reduce the risk of serious cardiovascular events in people with overweight and obesity. And so now we have long been talking about obesity as a modifiable risk factor for heart disease. But what I'm going to address today is that in some regards, that's a fallacy. In fact, obesity is actually not really that modifiable by lifestyle change alone, not sufficiently modifiable to reduce the risk of serious conditions resulting from it. But that's not the way we see it in popular culture, and it's actually frequently not the way it's addressed in medicine. It's seen as a finite, one-fits-all problem where people can just lose weight by implementing exercise and some lifestyle change and be done with it. But that's not what our science of the last 30 years shows, and it's also not what individual experience shows. For most people who undergo a lifestyle-mediated behavioral weight loss, they will regain weight over time, and that can prevent them from receiving the sustained health benefits of weight loss. So these discoveries have really led us to shift away from a view of obesity just as adiposity in and of itself being the problem, and more towards our scientific understanding, which is that obesity is a condition or a disease that's a disorder of energy homeostasis and is characterized by the defense of that elevated body fat mass. So that's what I'll be covering today and relating it to our new therapies with the following specific agenda. I'll review the central control of energy homeostasis, as well as the neuroendocrine response to weight loss. We'll touch upon the neurobiological basis, possibly, of how our body has evolved to defend body fat mass, and then integrate that into our new era of obesity care with all the rapid developments in our current and future treatment landscape, with some conclusions and clinical implications. So let's start again on central control of energy homeostasis. Back in 2023, Science devoted an entire issue to the hypothalamus, in which they deemed it small and mighty. And that is because it controls so many of our physiologic systems and their homeostasis. that includes our neuroendocrine axis, but also autonomic systems, and regulating physiologic functions like sleep and temperature, reproduction, as well as social interactions, and what I'll focus on today, which is energy balance. So back in around 2000 or so, this was kind of our view of the central control of energy homeostasis. This is a feedback loop similar to our other endocrine feedback loops, where our fat in the periphery releases signals that include insulin and the hormone leptin, which then are feeding back to the brain, particularly the hypothalamus, in order to provide input on the state of energy stores in our body system. As leptin acts on our system, it will tend to suppress food intake and also to raise metabolism. And that will work to hold energy balance. The opposite also occurs, so that when leptin levels fall, there is enhancement of appetite by these green arrows, accompanied by a dual component of that pathway, which is suppression of metabolism and encouraging of energy efficiency. So these systems are a homeostatic feedback loop. They're just like our other feedback loops for thyroid or reproduction. But the difference is that this is a homeostatic system in which behavior is the regulated output. And so when this system is active, what we're really changing are our behaviors around food intake, because that's the only way we get nutrition into this system, is by being motivated for it, obtaining it, and consuming it. So when we first discovered leptin, we thought we might be able to significantly impact this system. And that's because the rodents who had no leptin became obese. So we thought, okay, obesity is a problem of lack of leptin, and we just give it back and the problem's going to be solved. But that's not actually what turned out to be the case. So as you see on the right in this graph, as the percent of body fat increases, there's an exponential curve where you see marked rises in plasma leptin. But what's the problem here? The problem is that the leptin is no longer suppressing appetite or encouraging energy expenditure to the point where fat stores are reduced. And so this was the first hint that there was something going on at the level of the brain that had been altered during the process of obesity, and is part of our fundamental understanding of obesity as a chronic condition based in the brain. So let's add a few more details to this regulation. So on this graphic, you see here in this triangular section, the arcuate nucleus of the hypothalamus. And it has two key neuron populations. One are these POMC neurons, or pro-opiomelanocortin neurons, and those are responsive to leptin. And they're going to tend to guide our anorexigenic or appetite suppressing effects. They're in communication with other nuclei throughout the hypothalamus, as well as direct and indirect communication with distant brain regions that control behavioral aspects like motivation. Receiving feedback from signals of nutrition in the gut, like our satiety signals, including GLP-1, but also insulin and other circulating nutrients. These POMC neurons are accompanied by a second set of neurons that are known as NPY or AGRP neurons. And these are going to be our orexigenic pathways that will tend to be stimulating appetite and increasing food intake over time. So many of these things were defined in preclinical models, but how do we come to understand how these processes work in the brain in humans? Well, for that, what we've used over time is a technique called functional magnetic resonance imaging. And that's where we use MRI to indirectly measure brain activity, specifically in response to a stimulus. And so what we've done is we've shown images of mostly foods to people, and we monitor their brain using fMRI and are able to discern the regions that are reacting to those food cues. And by so doing, we can determine areas such as this small colored dot on the brain where there was excessive or additional activation in response to the stimulus. So, what does this tell us about food intake? We have been using it to understand the process of eating because I think that visual identification really starts almost all food intake for humans. And in fact, our brains are finely attuned to food in our environment. We can identify food and categorize it as either according to its energetic properties within 300 milliseconds. So you all knew these were donuts as soon as they popped up. The next step in eating is actually sort of integrating all of the various inputs regarding our motivation to eat. So that could be hormonal signals arising in the gut or from the periphery, as we've discussed. It could also be social signals. Maybe there's somebody standing next to us when we're having our in front of the refrigerator moment, or maybe we're trying to undertake weight loss and want to limit what we eat because of that. And once all of these inputs are integrated, we're going to go ahead and then execute the motor actions necessary to acquire and consume food. And so because that visual identification process is at the beginning, we've been able to understand how appetite regulation happens at the level of the brain by showing people images of food. So now here's some examples of the slides that people have watched in our scanner. So I don't know about you at home, but there's people in the room that are eating lunch. And so maybe this has made their lunch more appetizing to them. And so that's what happens. All of you, I think, recognize those foods really readily. You knew what was an object and what was a food. And what we've done is tried to understand what areas of the brain are actually more responsive to images of food than images of, say, couches. So when you compare how the brain responds to chocolate versus couches, you see certain regions pop up. And these are key regions involved in regulating both energy balance, like the hypothalamus, but also what's called motivated behavior. So motivated behaviors are dopamine-driven behaviors, particularly like reproduction, all involved in survival, and also food intake. And those are housed in regions such as the ventral tegmental area within the midbrain and regions like the striatum, which you see on the bottom, or nucleus accumbens. Also, areas like our taste centers in the insula popped up, and visual association regions in the hindbrain. So what happens when you show people the images of the low-calorie foods and compare that to couches? Well, these are the areas that are activated by those foods. So if you're on Zoom, you don't need to adjust your screen because there really wasn't any of the same reward and motivation regions that pop up. Our brains are just not similarly attuned to these low-calorie foods in the environment, even when they're beautiful carrots or strawberries, like those that we show. So what does this tell us? It tells us that the brain is selectively attuned to high-calorie foods in our environment. And actually, it turns out that these responses are a marker, a neurobiological marker of appetite in the brain. And how do we know that? From studies like this one by Tony Goldstone, where we looked sequentially at the 4 different regions involved in motivation and perception of reward and examined them in individuals who were either fed and then returned in a fasted condition. And what you see is that when people have increased appetite related to fasting, the solid lines, which are their responses to high calorie foods, go up. And the dotted lines, which are the responses to low calorie foods, if anything, kind of go down. And so fasting sort of biases us towards these high calorie foods in our environment. And we went on to show that this is actually proportional to the degree of hunger that people are experiencing subjectively, meaning that as people become more hungry, their attention for high calorie foods is relatively accentuated compared to their attention for those low calorie foods. Through experiments, we've shown that these brain responses are not only enhanced by fasting and hunger, but also by infusing an appetite-stimulating hormone called ghrelin, which is released in the stomach. And they're reduced by not just food intake, but by the hormone leptin when it's exogenously administered, or intranasal insulin, or infusions of combining two satiety hormones, GLP-1 and PYY, or a GLP-1 receptor agonist, liraglutide. So the process of satiety is one in which we're suppressing our motivation for high calorie foods. And we hear from folks who are using pharmacologic means like GLP-1 agonists that these medications support their making healthy choices. So it's not just simply about suppressing hunger, it's about really altering people's perception of food in their environment in a way that makes it easier. So what's one of the a quote from my patient? I feel like I'm on a pedal assist bike. There has been a total change in how I feel about food. I am less interested in certain foods. My nighttime fridge raid results in zero food or a pickle. I still enjoy what I eat, and I know that I'm consciously trying to make different choices, but it's not just me. The medication is peddling too. So these medicines are a way of supporting people in making it easier when they're trying to manage their eating habits. All right. What happens when people are undergoing weight loss that might make it even harder to sustain those healthy systems? Where there is a whole physiologic homeostatic response which counters weight loss. This is a weight trajectory from a participant in one of our behavioral weight loss studies where we followed them out for 18 months. And you see a pretty typical pattern where they're losing weight pretty readily initially. They have a plateau and then some weight regain, which sometimes is modest and sometimes regains even above their initial level of weight. And there are multiple homeostatic counter-regulatory responses when an individual loses weight beyond that exemplify this defense of the elevated body fat mass. Some of them are endocrine, falls in leptin, falls in thyroid hormone. Some are metabolic, potentially as a result, including reductions in energy expenditure and increases in energy efficiency on the part of muscle. There are changes in our autonomic tone with decreased sympathetic tone and increased parasympathetic tone, and then appetitive changes, which I'll talk about now. These include the fact that after a 10% weight loss, people report a reduced amount of fullness, even when they're given the same meal, as well as a reduced perception of the amount of food that they've eaten. And this is not only true in the adults in this study, but also in a study that we did of children. So these are children with obesity who underwent a behavioral weight loss program in a family-based behavioral treatment mode. They lowered their adiposity as reflected by BMI Z-score and fat mass, and they had a resulting fall in leptin, which would be expected. But what they also reported to us is that when given the same meal, they had a less of a reduction in their subjective sense of hunger. And when they went to a buffet meal after that test, they ate more calories of their estimated daily needs at that buffet. So clearly there is a shift, and that shift is happening at the level of the brain. Because these same children did the MRI with food cues. What we saw was that for the children that had the most amount of weight reduction during the family-based behavioral therapy, those children also had the most reduction in the degree to which their responses to high calorie food cues were suppressed by eating. This was not true about the low calorie foods. So what does this imply? It implies that after a weight loss, as people have a subjective reduction in satiation, one of the things that's happening is that food is no longer suppressing these very potent, motivating regions of the brain, specifically for these highly energetic foods in our environment. So we've also been looking into the metabolic shifts that occur with weight loss, and this was done with a research assistant professor in metabolism, Dr. Anna Valencia, who's been looking at the mitochondrial respiration of peripheral blood cells after weight loss. And these are a human study of individuals who were sampled during a weight loss plateau after behavioral weight loss or during weight regain. And what it shows is that the T cells have become more efficient. Their maximal respiration and their ATP driven respiration is reduced. This was an unexpected finding because we don't typically think of blood cells as very metabolically needy, unlike our muscle or our heart or brain. But in fact, adaptation to weight loss is widespread throughout our bodies. So, what can we take from this data to our clinic? Well, many patients still struggle with guilt or self-blame around efforts at weight loss that they were not able to maintain in the past. And it's important for us not to just know this complex biology, but to share it with our patients in order to sort of relieve some of that shame or guilt and reassure them that it's not their fault. All right, moving more into a potential means by which the body sort of resets at this higher body fat mass. And this has been an area that we've been studying for the past about 10 years. And what it focuses on is the same region of the brain in the arcuate nucleus, represented here in this graphic, but not just the neurons in the brain, those POMC and MPY neurons, but the cell types called glia that are also present. And these glial cells, including astrocytes and microglia, which are brain macrophages, have recently been shown to also have independent roles in regulating energy homeostasis and appetite, along with glucose regulation, lipids, and other peripheral metabolic physiologic functions. And so what we've been studying is the occurrence of inflammation on the part of these cell types in response to high-fat diet feeding in rodents. What does that look like? Well, what it looks like in a rodent is that when you give them a high-fat diet, and look at this area, this body weight regulating area of the brain in the arcuate nucleus, what you see is a shift in these glial cells toward a more reactive conformation. They're essentially being activated and they release cytokines and they take on a different conformation. And that response is typical of the brain's response to all types of inflammation and injury. So it's present in ischemia, it's present in spinal cord injury, it's present in autoimmune mediated inflammation. And what we're doing there is looking at how that inflammation then subsequently affects hyperphagia and weight gain in rodents. And I'll show you that data in a moment. The translational aspect of it has been a major effort in our group since then, which is that we have been looking at both autopsy samples and using MRI to determine if this hypothalamic inflammation and gliosis is also occurring in humans. So in autopsy samples, they've shown evidence of these activated glial cells within the hypothalamus in obesity. And using MRI, we've demonstrated radiologic evidence that these are present in obesity in both children and adults, in insulin resistance, in type 2 diabetes, and most recently in hypertension independent of adiposity. So what does this look like in a rodent? The key thing about this process is that it's present during the development of obesity and it doesn't precede obesity. So we think it's actually part of the pathogenesis of this chronic condition. So if you look closely at these data from a 2012 paper with Mike Schwartz and Josh Thaler and others, what you see are these chow-fed animals. And the dots you see there are microglia that are in their resting conformation, where they're acting as surveillance immune cells. They have small cell bodies and these long processes that are reaching out. But as high-fat diet feeding begins and progresses over 1 to 14 days, you see increases in the number of microglia as well as their size. And you also see changes in their shape that reflect this activation. So the cell bodies plump up and the processes kind of retract and become more stubby. And so that precedes weight gain and also is developing along with the hyperphagia or excess eating that leads to diet-induced obesity in mice. And this group, as well as others, have shown that if you genetically or pharmacologically alter this process, you can prove that it is both necessary and sufficient for weight gain and diet-induced obesity in mice. In this particular study, we gave the rodents high-fat diet for up to 8 months and also demonstrated reductions in these POMC neurons that are leptin sensing within the arcuate nucleus of the hypothalamus. This area has importance for regulation of, potentially for regulation of this defended level of body fat for the following reason. What we know from researching it over time is that when these insults are mild, this inflammation occurs and then can resolve, and the area goes back to normal levels of function. But when an insult is severe, you can develop what's called a glial scar. And a glial scar will inhibit the function of local neurons. It will inhibit the function of these surveillance cells in the region that are protecting the neurons, but also remodeling their synapses, and could have significant long-term consequences for body weight regulation in this key control center in the brain. So in humans, this is what it might look like. In C, you can look at a slide of astrocytes from the arcuate nucleus under the microscope that are stained in brown. And what you see are these sort of enlarged cell bodies and thickened processes that are kind of overlapping each other and almost like wrapping these neuron cell bodies that you see on this image. Those same findings are not present in a sample from an individual without evidence for gliosis using MRI. So these are autopsy samples from the arcuate nucleus in a human, sort of demonstrating the potential that this process is present. So we don't have a lot of information about how this might alter the defended level of body adiposity, but there is a little bit, and it actually comes from a study of the effect of GLP-1 on the defended level of body fat mass in rodents. And what you see there, it's going to take a little bit of information for you guys to understand. But what they did is they fitted high-fat diet feeding in a group of animals who were just maintained on that high-fat feeding. And then in another group, they maintained them on low-fat diet feeding. A third group of high-fat diet-fed animals were then given liraglutide in order to induce weight loss. And the final group was given the same amount of food. They were pair-fed to the amount of food eaten by the animals receiving the liraglutide. And at the end of the study, you'll note that those two groups had very similar body weights prior to being examined. So what resulted in the difference here? What they saw was in this black line, the animals who received the liraglutide had lower levels of microglia within this body weight regulating area of the brain, reflecting lower cellular levels of inflammation. And they were actually even lower as compared to the animals who received the exact same amount of food and had the exact same body weight at the end of the study. So there may be something protective about these GLP-1 receptor agonists in the brain. Similarly, the argument that they seem to reset the defended level of body adiposity is because when you looked at the hypothalamus in these rodents, these animals, again represented by the black bars, had lower levels of our appetite-stimulating neuropeptides, NPY, and AGRP, as compared to the pair-fed animals. And the opposite was true of our appetite-suppressing peptides, leptin, POMC, and CART, these leptin-mediated signals. So these are very preliminary information, and I think the verdict is still out by this, but this is one possible way where there could be structural shifts within this body weight regulating area of the brain that are progressing over the course of weight gain and come to reset the defended level of body adiposity. Well, we've done a lot of neurobiology. For those of you who don't care for it, you can take a deep breath because we're going to move into GLP-1 therapies and their implications for obesity care. All right. How to understand how these work? Well, let's start with how native GLP-1 impacts brain regulation of appetite and eating. So we already talked about this process of eating, but what happens after food intake? Well, after food intake, there's a cascade of signals, including a fall in ghrelin, increases in release of GLP-1 and PYY from the intestine, as well as CCK, and the sense of gastric distension. And those are going to feed back primarily, but not exclusively, through vagal afferents to the hindbrain, areas such as the nucleus of the solitary tract. Those satiety signals are accompanied by changes in circulating nutrients like glucose, as well as hormones like insulin that are also going to be providing feedback to these areas of the hypothalamus. And these areas of the hypothalamus are in constant communication with our hindbrain satiety centers. So what they're doing is essentially kind of turning the gain up and down on signaling within these hindbrain satiety center regions. So when leptin levels fall, the hypothalamus kind of releases and activation or damps down on activation by satiety signals coming from the gut, essentially turning the volume down even on our natural body's satiety signals. And as we've talked about, these energy balance systems are acting through effector pathways that alter our motivation and our attention for foods, specifically high calorie foods in our environment, in order to make us feel more satiated. Because when you think about satiety, it's really that sense that like you want to push the plate away and the food's just not that appealing anymore. All right. Again, what does this natural system look like? When you look at 24-hour hormone profiles, you see these meal-related excursions. So we're used to thinking about this for insulin. When carbohydrates come into the system, pancreatic beta cells secrete insulin, and we see a rise peripherally that falls during the intermeal intervals. Well, the same is true for our satiety, intestinal satiety signals like GLP-1 and also like GIP, or gastric inhibitory peptide. These are going to rise starting in 15 to 30 minutes after eating and peaking around 30 to 60 minutes after eating. Then they're going to fall while we're not eating, rising again at the next meal. Now, back in the early 2000s, people started doing mechanistic studies where they were infusing these hormones in order to better understand their effects separate from the effects of nutrition in the gut or the effects of gastric distension. And so by comparing individuals receiving saline and PYY in a crossover study, what they showed is that if you infuse PYY, which is another of these satiety signals, you can reduce not just meal intake, but 24-hour intake. And that was true both in individuals with obesity and in individuals without obesity. Now, why is this important? Well, you remember that differentiates it from what we saw with leptin, where leptin was no longer effective to suppress appetite. The satiety signaling appears to be intact in obesity. And so these agents kind of rocketed up to the top of therapeutic targets, potential therapeutic targets for managing obesity and for drug development. And what does the result look like? So this is a figure of the GLP-1 receptor, and our peptide GLP-1 receptor analogs are really amino acid homologs or proteins that are designed to mimic native GLP-1. So they bind to the extracellular domain of the GLP-1 receptor and cause it to stabilize in its active conformation, resulting in intracellular changes in signaling. And they've all been modified. So the peptides have been modified in order to resist enzymatic degradation. GLP-1 is degraded very rapidly, primarily by the enzyme DPP4, but these are stable agents that provide sort of sustained systemic exposure and prolonged receptor activation in the system. And as a result, we now see the most potent, we now have the most potent agents available to date for treating obesity in terms of weight loss, with our dual agonist acting both on GLP-1 and GIP, resulting in an average of over 20% weight loss in 72 weeks for those who were able to stay on the medication that whole time. So the other thing that I want to draw your attention to is that these agents also are increasingly able to produce the amount of weight loss required in order to modify significant health concerns associated with obesity. Well, what do I mean by that? This is modified from the American Association of Clinical Endocrinology recommendations, and it's a table that helps us establish our treatment goals when people are choosing to use weight loss to modify their health. So there are a number of things you can improve with weight loss. In prediabetes, you can prevent diabetes, you can lower blood pressure, you can lower peripheral lipids. You can lower blood glucose in people with type 2 diabetes. And a lot of those happen around that 5% weight loss. And that's 10 pounds in a person who weighs 200 pounds. But for some conditions, you actually need a little bit more weight loss. For instance, in MASH, in obstructive sleep apnea, you really need to achieve that 10% or more in order to modify those conditions. And that's how we think about establishing treatment goals for our patients based on their health comorbidities when they're present. So now that we're achieving greater degrees of weight loss and we have GLP-1 that's active not just in the brain, but across multiple organ systems, we're starting to see indications beyond obesity for these medications. So we're all familiar with their use in diabetes, but now treating moderate to severe obstructive sleep apnea is an indication, treating MASH to reduce steatosis and fibrosis, treating individuals with diabetes and chronic kidney disease to reduce kidney-related complications, and to reduce the risk of serious cardiovascular disease events in individuals at high risk for cardiovascular disease. So how do I talk about setting these goals with patients? Well, for me, we now have a number of different tools that we can use to manage weight. And some of this discussion needs to be, what is the weight loss required to modify some of the health conditions? And so as I think about our options, we have lifestyle in our toolbox. You can use lifestyle alone, and on average, people will achieve and maintain a kind of a 2 to 3% average weight loss, which can improve health for folks. For folks who do our gold standard intensive lifestyle intervention, they're much more likely to have around a 7% body weight loss, which isn't always maintained long term. When we add pharmacotherapy, we're adding between 5 and 20% weight loss to lifestyle. And so I'll talk about what agents are in that range. And finally, bariatric surgery, which still is our most reliable means of producing a sustained large weight loss on the order of 20 to 35% of initial body weight. It's also still the area that we have the most long-term data, including 20 and 25-year data on resolution of metabolic disease like type 2 diabetes, obstructive sleep apnea, prevention of cardiovascular disease, and even improved mortality. So our pharmacologic toolbox has really expanded. And each time I remake this slide, I have to extend the y-axis for the percent weight loss seen at 1 year. So on the left, you see some of our older agents, including the over-the-counter agent orlistat, and our once daily GLP-1 injectable liraglutide, as well as our combination therapies, bupropion, naltrexone, and phentermine topiramate. What you also see is that very consistently, there is a greater amount of weight loss in individuals with obesity or overweight and a comorbidity than those with type 2 diabetes. It's true in clinical trials and in clinical practice. Our newer agents, including our injectables, semaglutide, tirzepatide, achieve on average, greater degrees of weight loss that is usually accompanied by more reliable improvement in comorbidities as well. And these are placebo-subtracted weight loss. So what you see in addition to what people might see doing a lifestyle therapy alone. And finally, our most recent additions to this are oral semaglutide and on April 1st, orforglipron, which I'll talk about now since we have the opportunity to hear about this new medication. First, I just want to mention that some of you will be familiar with phentermine, which is approved for long-term use in combination with topiramate, but has not had long-term trials published in the past. There is one coming out at the end of December, which I think will give us some good data on a generic and cost-effective option. So orforglipron was just approved by the FDA on April 1st. These are the ATTAIN-1 phase 3 trials in over 3,000 adults with obesity or overweight, in which they received 3 different dose regimens or placebo. They saw an average of 7.5% to 11% body weight loss based on the doses, and it was dose dependent. And there were similar side effect profiles with 3.5% to 7% of individuals needing to stop the medication related to side effects. Why is orforglipron different though? It's actually a first-in-class medicine because it's a small molecule. So the ones that we've talked about to date are proteins. They get digested in the gut, and that's why we're having to give them as subcutaneous injections. But this is an oral medication taken once daily. It's also going to be easier to manufacture and distribute. It doesn't require refrigeration. And so while some people may want this as an individual choice, it can be manufactured to scale and maybe might be appropriate to help alleviate our global obesity problem as well. It does require dose escalation, as all of these medications do, to reduce side effects from this constant stimulation of the GLP-1 receptor with initiation. The side effect and contraindications are similar, but there are some new drug-drug interactions to be aware of regarding that could affect its therapeutic efficacy or could, for example, increase the risk of myopathy with concurrent simvastatin, which is recommended to be limited. So those are some of our current agents available, and there are a lot of medications on the horizon for the future. So this is from September of 2025. And since then, 2 of these have actually been even brought to market, which is oral semaglutide and orforglipron in the last few months. But as we look at these, what we see is quite a few in phase 1, a large number in phase 2, and I want to highlight a few. One is Maritide. Maritide is a once monthly dual GLP-1 GIP agonist that is having similar weight loss effects to the once weekly. Another is retatrutide. This is called a triagonist or triple agonist. It acts at the GLP-1, GIP, and glucagon receptors, and it to date has demonstrated the largest average weight loss in clinical trials. And finally, CagriSema, which brings not just GLP-1, but amylin stimulation into practice. So diversifying these hormones that it's acting upon. All right. How are these evolving our treatment of obesity? Well, there are still areas that are fundamental to obesity care. So providing obesity care still involves behavioral counseling, helping people improve their nutrition in a manner that improves their health, helping them adopt aerobic and resistance activity, helping them engage in self-monitoring, which is proven to improve weight loss and weight maintenance, and then addressing any weight-promoting medications and limiting those if possible. The goal for individuals who don't have comorbidities is preventing their development, and that's something we're going to work through with the patients over time. These are recommendations from the American Diabetes Association that are published there. There's also excellent recommendations from the American Association of Clinical Endocrinology and the Canadian Obesity Association. And when individuals have comorbidities, we're starting to emphasize relying on our evidence to select the appropriate agent titrated over time and address their health risks in that manner. So foundationally, obesity care is now characterized by a conceptualization of obesity as a complex and chronic neuroendocrine condition. The treatment is longitudinal. It is progressively increasing in its complexity, where we have a toolbox of approaches that are used sequentially or in combination, and we'll continue to have evidence about those combinations and sequences emerge over time. And finally, it's person-centered. So last year, I, along with a group of other investigators and clinicians, published an article talking about how to perform person-centered care and arguing that it really has 4 key principles. One is it needs to be bias-free. So a person needs treatment that's coming from a place of compassion and care. It's free of stigma and blame. Needs to be based on some of the science that we've talked about and involve education, not just of ourselves on this science, but of our patients and their families, and providing evidence-based treatment in addition. Emphasizing patient autonomy. There are patients who have had very difficult experiences with weight loss, and those folks may not want to use weight loss to improve their health. We can need to respect people's decisions and help them manage their health with other means. And also access to care. For me, I think that weight bias and stigma is still limiting people's access to these medications. And so we want to be advocates for our patients, but also understand that cost and coverage might be limiting their treatment options. So to wrap up, what have we learned? Hunger is not equal for all foods. Our brain is attuned to the high calorie foods in our environment, and weight loss will tend to increase the attention or motivation for high calorie foods. Modest weight loss improves health. While we now can have larger weight losses, these newer medications also provide reliably sufficient weight loss to manage health in a variety of different conditions. We're really treating the brain. So GLP-1s in particular are acting to modify our body's natural appetite regulating systems, and they support not just weight loss, but weight maintenance when they're used as recommended and maintained over time. So what do we talk about with patients now? Are you feeling full when you eat? Do you get hungry? Are you getting food cravings? Is it easy to stick to your eating plan? And when we do this therapeutic management of their behavior well, we hear things like, I feel like I'm eating normally for the first time in my life. Now when I feel full, I just stop eating. And it used to be so challenging. My weight was just keep going up. It's like a miracle. So bringing it back to the beginning, what I'd like to emphasize is that understanding this neurobiology for the past 30 years, we've now come to a moment in which we really can treat obesity as a modifiable condition. By addressing its neurobiology appropriately, we can improve quality of life for our patients, their clinical outcomes, and even save lives. So thank you all for your attention. I want to acknowledge the folks on my team that I rely on every day at the Brain, Body, and Appetite Research Collaborative, the folks in endocrinology and in radiology I collaborate with, and my funders at the NIH and American Diabetes Association. Thanks a lot for your attention.
Well, can I ask a question?
I would love that, Conrad.
One question, I'll start off with one. I'll let you answer that in just a second. The first is when Ed Cook was out here, a couple of years ago, he and I sat down and we were talking about GLP-1 and everything. At that time, too, GLP-2 agonists were being discussed as other agents. Can you contrast the effect of GLP-1 agonists versus GLP-2 agonists? And also, think there could be a combination there because that's what we were discussing.
Yeah, among the agents that are really moving into phase 2 and phase 3 right now, the combined GLP-1, GLP-2 agents aren't prominent, and I think that doesn't mean that they won't come along, but others are just farther advanced. So I guess that's what I would say about the state of the.
What are the contrasting effects of GLP-1 and GLP-2? In other words, are there unique features of GLP-2s versus GLP-1s and vice versa?
Yeah. So, in terms of that, I think mostly what we have found from the GLP-1 agonists is that they have these central effects, and that's what's most potent in weight. Whereas GLP-2, my understanding is that they may be working more at peripheral stimulation. So, just a difference there in what the indications might be and what they might be used for. Yeah.
So the second question I have, Ellen, is almost every day or every other day you read in the lay press or in one of the feeds that I get about some new side effect of GLP-1 agonists.
Mm-hmm.
I mean, I can sort of buy the pancreatitis and the gut paralysis and that sort of thing. But how about the latest one that I just saw, I think today or yesterday, was decreased cognition? What do you make of these reports?
Yeah, so surprisingly, these have actually been under study for increasing cognition, and that is one area where they haven't proven to be effective in that when tested in people with dementia, they did not improve their cognition over time. So I can't comment on that particular report. I will say that monitoring people on these, we actually pay very close attention to their state of nutrition because sometimes people have very potent appetite effects and they're really not getting sufficient calories that their brain and body needs to function. And so we monitor them for fatigue and for maintaining adequate nutrition, adequate protein intake. And those are the things that I'm really looking at when I think about that. The thing about these agents is that, they've actually been around for a while, used for diabetes and now obesity. And we're starting to get more and more long-term and large sample data where there's really not novel, serious side effects emerging. And in fact, the benefits appear to be outweighing the risks. So I'm positive that people are experiencing many different things on these medications, but the data that we have to date, from clinical trials and the reliable data, I think are pointing us in the direction that the benefits outweigh the risks. Yeah.
Did I figure it out? I did figure it out. We had just been talking before we came to this conversation today about an ad I saw yesterday that was promoting, GLPs for patients just to lose like 10 pounds, 5 pounds or anything, and patients that don't have obesity but might be overweight or something. I was wondering your thoughts on that and like how you see this being used for patients and what we should advise patients, because I feel like in our primary care clinics, I'm getting those questions and I don't quite know what to say.
Yeah. So, as a physician, I think we need to think about the FDA indicated folks that these are really meant for and targeted. And because it's the area of weight and we have a culture that is, for lack of a better word, messed up around weight, they really have leaked into a lot of different areas of popular culture. And those uses have proliferated. What I would say is that when folks come to us as physicians, I personally, give guidance that, we want to use them for what they're indicated in. Now, that being said, the new definition of clinical obesity includes things like waist circumference. And so there might be people out there who have lower BMIs, but are still at high risk. And so as a physician, you want to take those things into account. For folks that are using them for body image purposes, what I would say is that they are taking on additional risk to use them in that way. And that we do not yet have the data that shows that those risks provide additional health benefits over the long term. So I know that doesn't address all the body image concern that our patients come with. I do frequently have to talk to people about those targets and the goals for improving health, because they may have a number in mind that's different than that. But the benefit is really about the journey and not the destination. And so once they're at that 10%, if they're at that 15, or maybe they got to a 20% weight loss, they have achieved sufficient weight loss to have health benefits. And for a lot of folks, that can help them relieve that feeling like, well, I really need to be at the 140 pounds that I was at when I was 25, because we do still hear that a lot.
I was wondering if you could comment on the mortality benefit that you showed on the very last slide. Spooky.
We have mood lighting all of a sudden.
I know. And specifically, I was curious what you thought about the mechanism there. Is it simply like you're reducing hypertension? And so,
Oh, yeah, that's a great point.
Yeah.
So, hopefully you all heard the question is about the potential mechanism of the cardioprotective effects of GLP-1s. So this is an area of debate and research. So there appear to be weight independent benefits. And as we spoke about, not just GLP-1, but GLP-2. So GLP-1 is receptors are widely distributed across the body. And so there could be effects on peripheral inflammation, direct cardiac effects that could be providing some benefit. And some of those things are still under study at this time. And in other situations, some of the effects are also not weight dependent. And so there's really a flurry of activity to better understand this and figure out if we have other ways to tickle those exact same pathways to get that cardiovascular benefit. Did that answer your question? Okay. Is there any questions online?
there's a few questions online. Is there a role for these medications in non-obese patients with hypertension or pre-diabetes?
Yeah, so another great question about is there a role for these medications? I feel like that's an area where research is really needed. So as we talked about, with the clinical obesity, thinking about waist circumference and elevated risk, the studies still are limited to folks with a BMI of 27 or higher. Remember that there are some ethnic specific BMI definitions, meaning that folks of South Asian and East Asian heritage are at higher risk of metabolic concerns at lower BMIs. And so the proposed cutoffs there are 23 for overweight and 27 for obesity. So that's one population where you might really think about kicking these in at a lower BMI because they have demonstrated increased risk at lower BMIs. But it's a really interesting area, and I think there will be developments in it over time.
Another question in the chat is asking or is commenting that they've been reading that people are not requesting the new oral drugs as much as they would have expected and don't seem to mind the injectables, and they're wondering what your experience has been with that.
Yeah, so people are driven by different aspects of it. Some people don't like the idea of injections, and so I think having other options is important. But once a week is pretty convenient for people to do it, and that weighs in. I think cost and availability also weigh in. So with both the forglipron and with the semaglutide, they're at a lower price point, and I think hopefully that's going to drive competition and continued price variability, making more insurers actually cover them for obesity, and making them more available for those who have to rely on self-pay because they don't have coverage.
And we are at time, but I do think there's one great question in the chat I would like you can answer. Is there a role for preventive GLP-1s in patients with like a history of syndrome, or if their BMI is 25 to 30, which you kind of addressed in that previous question. But they're getting at, could this help patients have a pathway for not being dependent on GLPs lifelong? It seems like once the weight has been gained and the glial scar has formed, it may be too late to reset the body's defended body weight without the use of
Yeah,
GLP-1.
that is super important. And it just highlights the fact that we still need prevention, particularly for our children. They need to have access to nutritious food options in order to stop this process before it happens. And it may be in the long run, we also consider pharmacologically mediated therapies. But right now, our prevention is at the lowest risk, which is behavioral changes. Yeah. Thank you.